Good morning, ladies and gentlemen. Good afternoon, good evening. It's a great pleasure to start the third part of our International Symposium of Cardiovascular Genetics. Today, we will have 4 different lectures. The first one will start in a few minutes, and I would like to thank our post-graduation course in cardiovascular science and cardiology for the opportunity to be organizing this event. Last week, it was really fantastic, and I am quite sure that this morning, in Brazil at least, morning, we'll have a great day of lectures and also discussions. Well, the first lecture will be held by Dr. Luciana Sacilotto. She's a cardiologist at São Paulo Heart Institute, also a PhD in cardiogenetics at University of São Paulo, Brazil, and a specialist in arrhythmia and cardiology. In the next 30 minutes, more or less, Luciana, you will be talking about long and short QT syndrome and also Brugada syndrome. Be my guest. Thank you very much for being with us.
Thank you, Ricardo. Good morning, everybody. It's really a great pleasure to be here. Congratulations for your dedication with your students. It's a really special symposium to give them this international opportunity. And it's an honor to be part of your selection. So I will share my screen.
Okay.
So I will talk about long and short QT syndrome, and I will start about, I have no conflict of interest to declare. I will start about the short QT syndrome. This is the short part of the lecture. Is the short history.
The slides are not on the screen.
Sorry for that.
Oh, okay. It's something very.
It's something that we run in the speech, and then
this is it happened during the whole pandemic when we gave lectures. All
yes,
over. This is
for sure.
It's everything else said. Please.
So we talk about long and short QT syndrome. I have no conflict of interest to declare. I think short QT syndrome is very practical to start because we have like only small messages about short QT syndrome. We have also a short expertise, I think, the whole world, because we have only few cases around the world. We have this case that it's also in PubMed, a familiar screening in the diagnosis of short QT syndromes after a sudden cardiac death. We have this family that everything starts with 2 brothers that have died suddenly very young, and then this 18 years old boy went to INCOR because of recurrent syncopal episodes, and then we have this ECG. When we look to this ECG, we have nothing very remarkable. But then when we measure the QT, we can see that he had a shorter QT than the whole population, like a QTC around 30 and 38. And then we also understand that for short QT syndrome, we have... Oh, yes. And... And then for short QT syndrome, unfortunately, we have little answers in genetic testing. So this is a consensus, like expert consensus statement of of genetic testing in channelopathy, cardiomyopathy, and in short QT syndrome, we know that there is little to understand in diagnostic, prognostic, and therapeutic approach with based on genetic testing. And this patient that I presented, he had a negative genetic testing. And when we look for the genes, we can see based on the the work of Klingen, that we have few genes that can explain the short-QT syndrome with a classification definitive or strong in the role of the short-QT syndrome as an autosomic dominant mode of inheritance. We can see that the other genes that were stronger in the past, like KCNJ2, that was considered short-QT syndrome type 3, now we can see that there is a moderate classification to use this gene as a causative for short-QT syndrome. And so these genes, we didn't find any variants in these genes in the next generation sequence of these patients. But we can see that the diagnosis of short-QT syndrome is also challenging. If we have a short-QT less than 360, we have to aggregate one more criteria, or a pathogenic mutation. When we see a mutation that it's classified as recommended by current guidelines, we need to be very cautious with variants of uncertain significance, because you can see here that when you have a positive pathogenic mutation, it's very strong for the diagnosis. So we need to be very carefully when interpreting a genetic testing, a result. And we need to have a multidisciplinary approach to do not mistakes based on genetic testing. And then based on the case I presented, a family history of short-QT syndrome can be an additional criteria. And if my patient had survived from VF or VT, it's also aggregate for the diagnosis. So we can see that there is no class 1 diagnosis for the patient that I presented. If I go further, I can see that short-QT syndrome can also be considered in the presence of QTC from 320 to 360 and a family history of sudden death before 40. So I can see that my patient is a class 2B of diagnosis in short-QT syndrome. So it's something controversial, but it's the only explanation that I have. So we followed up this patient based on family history and syncopal episode. And in Brazil, we don't have implantable loop recorded. The team decided to inserted him on ICD, and we have a follow-up of 3-4 years. And he hadn't any syncope again or an ICD shock. We will see this in the future if we were correct or wrong. Unfortunately, in this case, we need to base it our ICD implantation in a discussion, in a shared decision with the family, with the patient, and with our team. For these challenging situations, we also have sometimes we can consider that a patient have a short-QT syndrome in the presence of a QTC under 320. So in this case, if there is no family history, no syncope, no VT or VF or atrial fibrillation, the QT needs to be really, really, really very short to consider it like a diagnosis. And this is based on the challenging of having like 0.05% of the population that have shorter QT interval, and they are not short-QT syndrome. So it's very important for us to not overdiagnose this condition, because this leads to a very important consequence in the family. So it's very interesting that this group tried to share some characteristics that can lead to a better diagnosis in a ROC curve. And what they found is that when you take children and adolescents, it's it's very important to see not only the QTC but also the JT peak interval and the presence of early repolarization. So when mainly children and adolescents, because they have a shorter QTC, they can have a shorter QTC. So if you observe QT less than that's why in the guideline we have 320, because in the past was 340. So if you have for this paper 316, so 320, and a GT peak less than 180, in the past it was 120, plus the presence of early repolarization when the patient is asymptomatic, of course. So it's more correct to say that the patient has an arrhythmogenic short QT syndrome and not a shorter QT in normal subjects. So this is very, very important. So when we have, if we look to the guidelines, to the recommendation, our patients should be considered for implanted loop recorder because of unexplained syncope. But if you also make a diagnosis based only on QT, it's also needed to discuss with the family an implanted loop recorder regardless symptoms. This is very difficult for us, as I said, because of the lack of implanted loop recorder in our daily routine. And ICD implantation should be considered in patients with arrhythmic syncope, but arrhythmogenic syncope must be documented. In our case, was not documented, so it's very difficult. I really think that quinidine is a bad joke, because I've been looking and trying to figure out how to have quinidine since I started on cardiogenetic research, and it has been a very, very difficult way. I think many countries in the world is in the same situation, but quinidine, based on a work of Pavia group, Mazzanti, they show that quinidine can reduce the arrhythmic events. It's really very important for us, because as EP study is very is an easy approach. It's very important for us to understand that EP study is not a choice in short QT syndrome, as well it's not a choice in long QT syndrome. So this is very important. So what I would say in short QT syndrome, that it's once diagnosed, secondary cause must be ruled out. It's something that I didn't mention, but of course, we need to have a calcium dosage, for example, some medications, but we have also a case of adenoma of parathyroid, and it's very important to rule out this. Our patient had like 16 of calcium, so after correcting and extracting the adenoma, the KT was within normal again. So it's important, as in other channelopathy, to rule out secondary causes. And then you need to have, of course, a close follow-up, because 30% of the patients come after a sudden cardiac arrest. And now we have to look in deep in this ECG additional marker, because we can have some clues that the patient has arrhythmogenic short QT syndrome and not only a short QT interval. So in some case, specific case, consider implantable loop recorder and ICD. So going to long QT syndrome, I can say about something about pathophysiology of long QT syndrome, that it's like an opposite of short QT syndrome. So you have loss of function of the potassium channel, the fast and the slow current. So when we have this, we have a prolongation of repolarization of course, as well as when we have the late current, the late sodium current. So this is important, because this can lead to early after depolarization and TORSA. The main age of symptoms in long QT syndrome, this is a comparison with other channelopathies. So here we have Brugada syndrome, and then that is for 3 to 40 years old. So long QT syndrome, we have like to 25 years old from birth, so we can have the diagnosis from birth as to 30, 40 years old, but we also have to follow up this patient till the entire life, because after that their arrhythmogenic risk can decrease. But sometimes patients can be exposed to medication, to antidepressive, to ischemic events, and the long QT syndrome can pronounce the arrhythmogenic phenotype and lead to sudden cardiac death. The typical form of arrhythmic expression in long QT syndrome is polymorphic VT and TORSA. So to have the diagnosis, we have the proband and the relative. For diagnosing the proband, of course, ECG, many ECG, as many as we can, but we can also do provocative tests with the exercise test, exclude acquired. And why to do exercise tests is sometimes to show a prolongation of QT interval, mainly in QT1 that we are going to talk a bit after, and to show to also in one point to explore the diagnosis, and the second point is to phenotype better and to understand if the patient has a long QT syndrome type 1, 2, or 3. In a relative, it's always when we think about a cardiogenetic disease, we need to follow up the family also. So family can do an ECG, an exercise testing, depending of the diagnosis of the problem and when feasible, because from birth, it's impossible. With 4 years old, 5 years old, it's possible. We do it at INCAR. We start the stress testing with 5, 4 years old. Sometimes we can help the children if they don't reach the treadmill, but it's easy to do, because then we have the 12 lead ECG. It's the main diagnosis. We don't need to use Holter monitoring. Holter monitoring is for follow-up. It's not for diagnose, because we have only 3 leads, mainly in Brazil. We don't have the 12 lead Holter. So we need to have 2 tools, ECG and exercise testing. Both are complementaries. So then we go to stress testing. We need to remember always that the stress testing we need to do in the proband, in the member of the family that has that have a more pronounced phenotype. It's important. So then, if the proband is positive for a pathogenic or likely pathogenic mutation, then we can base the diagnostic of the relatives also in this genetic testing. The long QT syndrome is very an exciting syndrome, because we have 15 years of research. This is a special article from Peter Schreier that's very interesting to understand. I recommend this reading, because it's very interesting to understand the history of long QT syndrome. So it's something that we have the best approach, I think, in channelopathy. This is a very famous slide from Ackerman that when we diagnose long QT syndrome, after that we think about the family and we think about what type of long QT syndrome are we looking for. So we have the long QT syndrome type 1, and the exertion, swimming, emotion are triggers for arrhythmia. So sometimes we have a family history that with death with a downing. Sometimes we have death during exercising at school. So we need to here to understand the triggers of the family, if the patient is asymptomatic, or the trigger of the patient if the patient show you some symptoms. And then we have long QT type 2, and in the same way, sometimes the problems that are looking for you tell a history of a grandmother that died in postpartum period, and then at that time they thought about thromboembolism and many other situations, but long QT type 2 can also explain a death in postpartum period. Sometimes these patients have can die during arousal periods because auditory triggers, because alarm clock. So it's very important to recognize these triggers, not only for diagnosis, but also for recommendation when we need to treat the patient and recommend some lifestyle modification. And in LKT1, it's avoiding swimming and exertion over the basic conditions. And in LKT2 is to think about postpartum period in women that want to have babies, but avoiding auditory triggers, modifying the alarm clock in daily routine. So it's important to use it not only in diagnosis but also in recommendation. Long QT syndrome type 3 is a bit different because we can avoid sleep, but then we need to understand that it's a different mechanism. So we also think about the late current, the sodium late current, and so in this case we think about specific medication. So here we have a panel of long QT syndrome patients, and I think that we need to training to recognize that, for example, in panel A we have a type a T wave that is it's typical for long QT type 2, because we can see that in lead V2 we have like a notch, in lead V3, in lead V4. So this is a pattern of phenotyping the ST wave, as well as in panel C. We can see that in long QT type 1. I think it's most difficult because it's very similar to a normal T wave. And then in panel D, and maybe for me it's the easiest because we have a ST segment very rectified. So we see that the repolarization started very late, and then the T wave can be tall or can be flattened like that, and this is the typical torsa. So we know that we have this description in the T wave morphology, but when we know that panel A is for long QT2, it's easy to see that there is a notch. But when we have an ECG, it's sometimes without family triggers, it's difficult to be completely sure that patient has a QT1, 2, and 3. Sometimes in QT3, this rectified segment is also present in calmodulopathies. So it's important to understand that this is not as 100% specific when we use the T-wave morphology, but it's something that is interesting to treat, to training our way of looking to an ECG. The explanation of this morphology is according to the current affected. So when we have long QT type 1, we have the depolarization start from endocardial to epicardial, and the repolarization is starting from epicardial to endocardial. So the endocardial that it's full of slow potassium current. Then when we have an impaired function of the slow potassium current, we have a larger base of T wave. The T wave, the normal T wave, finished with the mid septum, mid myocardium. So we have in this part the concentration of fast current of potassium. So when we have the impaired function of the fast potassium current, then we prolong the repolarization of the mid part. So we have this notch represented here because the T wave finished with the median part. And then we have from epicardium. So as I told, it's the beginning of the repolarization. So if the epicardium is full of sodium channel, then we have a slower beginning of the T wave. That's why we have a rectified ST segment elevation. So anyway, it's important to do the genetic testing, genetic counseling, to be sure of your diagnosis, the subtype of ECG, because it impacts in clinical practice. We can see that from 2011 to 2022, the role of genetic testing in long QT syndrome is high, according to diagnostic, prognostic, and therapeutic approach. So things didn't change so much for long QT syndrome and for HCM, because we also had a strong use of the genetic testing at that time, but we know that for cardiomyopathy this changes a lot, and in 2011 the role of genetic testing in cardiomyopathy was low, and now the role of the genetic testing in cardiomyopathy, it's really very interesting. A few years ago, the genetic testing in long QT syndrome was something very difficult to understand, because we talking about LQT from 1 to 17, and fortunately we can see, based on the CleanGen work, that now we have the definitive LQT syndrome. So I think that nowadays we don't need to talk about LQT 4, 5, 6, 7, 8, 9, we need to talk about LQT 1, 2, 3, calmodulinopathies, triadine, that is the lock syndrome, and then to the homozygous KCNA1 and KCNK2, Jervell-Long-Nielsen, and then we also understand the syndromic parts of long QT syndrome, that is now long QT 7, Andersen-Tawil, and long QT 8, Timothy syndrome. So I think it's better to understand LQT 1, 2, 3, calmodulopathies, and syndrome as stated by Europe, by the guidelines. So we have we base our diagnostic approach in the QT interval, when more than 48 milliseconds, we can have a high probability. We can also use the Schwartz criteria. It's a table to make it easier to use some points that you use the QT duration, the notch into wave, the results of exercise testing, and so we can sum some characteristics to have a high probability of long QT syndrome, not of a high risk, a high probability. And then we name it then LQT 1, 2, 3, and calmodulopathy. And then we have Jervell-Lang-Nielsen, Timothy syndrome, knockout syndrome, as well as Andersen-Tawil syndrome. Then we have the prognostic value of this disease. Long QT type 2 and 3 is in the highest group, mainly when the QTc is over 500, and it's also important to measure the QT, or the way we feel better using the tangent method, or using the T wave. And sometimes I look to a T wave, and I feel comfortable to use the tangent method that was published by Postema. And sometimes I look to the T wave, and I don't find a way to do the tangent method, and then I use the end of the T wave. But it's important to use a lead 2 or V5. We have different efficacy of beta blockers. It's important to remember that it's only propranolol and nadolol in this syndrome. Then we have nadolol for a specific LQT2 is more important in LQT2 patients, to use nadolol, but we don't have in Brazil, of course. But if we don't have nadolol, we have propanolol, and we need to be very strict to these two beta blockers. This is a case of 35 years old, that a girl that have vasovagal symptom in a family with many sudden cardiac deaths in this family. And then she had this was the response with propanolol. I don't know why, but she was also very tachycardia with this sinus tachycardia, and the KTC was over 500. And then with nadolol, it was possible to control the heart rate, and to put the KTC in a better condition, in a safe condition, to not use the ICD in a LKT1 patient that it's not that respond better to the antiadrenergic therapy. So we need ideally non-selective beta blockers, nadolol or propanolol. The recommendation doesn't. There is no approach to the other beta blockers. So we have also these girls with 42 years old, asymptomatic, a brother with an ICD, and she has a very typical variant in LKT3. The segment ST is very retified, and she has a before maxilintine and after maxilintine KTC. So it's important to observe how the KTC shortened with maxilintine. She has a 10 years follow-up, and she didn't develop any life-threatening arrhythmic event. The genotype also is important in pediatric group. We have this child with a 2-to-1 block, a functional block due to long QT syndrome, a very high interval, and we know that LKT3 can respond to, we know that it's a rare disease, but when thinking about long QT in babies that have syncope or arrhythmia during intrauterine period, LKT3 and LKT2 are most prevalent because they are really bad disease. So we need to use maxilintine, that it's also a drug that is not available in Brazil. We also have a problem with the consolid QT, prolonged QT interval, and then genetic finding can help. This is a modified long QT diagnostic score, so it's something that it's integrated with the Schwartz criteria. Schwartz criteria have everything that we have here, but the genetic finding was incorporated with a pathogenic mutation, so we need to pay attention how it's important to classify this variant, because we need to be careful, because a variant of uncertain significance, it's not diagnostic for long QT syndrome. And sometimes we have also acquired long QT syndrome. This patient was taking azithromycin and quetiapine in the beginning of the pandemic time, and what we need to do is to observe the patient with the washout of the drug, ECG, many ECGs, everyday ECG, provocative tests to see if the QT prolongs in the recovery time that is typical for long QT syndrome. And even if we think about acquired long QT syndrome, it's important for family screening, because sometimes for that patient the QT is consolid, and we have a brother or a sister with a very clear long QT syndromes. And sometimes genetic testing is also appropriate to see if this acquired condition is not a long QT syndrome that was consolid. So this is the final recommendation for patients with long QT syndrome, to summarize. But then we, of course, we know what to do with aborted sudden cardiac arrest, ICD implantation, syncope when it's not when it's before treatment and after treatment, syncope after the correct treatment also need an ICD implantation. Asymptomatic patient with or without pathogenic mutation needs to do the same approach, general recommendation to avoid triggers, beta blockers, the the right beta blockers. But if we have an asymptomatic patient with KT1, 2, and 3, we really needed to see the high risk features based on genotype and KTC to then, in some controversial cases, indicate ICD even in asymptomatic patient. This is something that needs to have also a heart team to and a shared decision with the family, because it's very important. So I want to thank also all my multidisciplinary team in saying that phenotyping deeply is very important for recognizing the true short QT syndrome, the true long QT syndrome, the best use of genetic testing to be aware of these creation genes and variants, the multidisciplinary approach, avoid mistakes, and genetic counseling prepare our patients better for receiving a diagnosis of genetic testing or for a genetic disease, not only when genetic testing is positive. That we have a very dynamic concept, and not only in phenotype, as you can see with long QT syndrome, but also in genotype. So I need to thank your attention.
Dr. Luciana, as you know, I am your fan, and now I am more and more fan. So,
thank you very much.
It was a fantastic presentation. Very, very, very beautiful slides, very clear. And as usually, you gave a fantastic lecture. In the next 20 minutes, we have the opportunity to discuss a little bit the issue. For sure, short QT syndrome is a rare, very rare syndrome. Andrea Massanti in Italy, he has the bigger casuistic, as far as I know.
Yes.
Dr. Diego worked with Dr. Andrea Massanti for a while in Coruña in Spain. And I invite all the audience, as well as our the other speakers, to ask you questions. But if you permit me, I have one question. As you know, I work in this interface between exercise cardiology, sports cardiology, and genetics. And I would like to ask you a question, because Michael Ackerman and the Mayo Clinic Group, they are working for a long time with athletes. Feel comfortable to say if you don't work with this, but what do you think about high performance athletes with long QT syndrome participating even in the Olympic Games? What is your opinion regarding this issue? I have my own opinion. Also wrote with Dr. Luis Ricci and Maurizio Milani from Brasilia. We wrote in European Journal of Prevention Cardiology a manuscript regarding this. But I would like to ask you, as a specialist, what is your opinion?
I think the high performance athletes needs to be heard. It's a shared decision, of course, but I don't have any long QT syndrome patient that perform this high
Dr.
performance.
Luciana, can you stop your presentation?
Yes.
Yeah, the screen, please.
Yes.
Okay, great.
So as you told, I don't have a practical with high performance athletes and long QT syndrome. Sometimes we had some experience with arrhythmogenic right ventricular cardiomyopathy, hypertrophic cardiomyopathy. Specifically with long QT syndrome, I had one girl that was a basketball player in the beginning of the career, and she had long QT syndrome type 2. She had syncope. She had over 500 of QT interval. So I shared with her that she had a high risk long QT syndrome, but I know that she doesn't have a long QT syndrome type 1. That it's the main trigger is exercising, but I didn't feel comfortable with her to allow her. And so I made only this consideration that I said to her that she was in the beginning of the career, that she was a woman, that the KTC was really, really, really very long, and she had a syncope. So I understood that she was not allowed to continue. But I had only a conversation. It wasn't necessary to prohibit because she was not there yet. So I think that with a shared decision, sometimes long QT type 3 with a good control without symptoms, it's possible to allow. I really appreciate the approach of shared decision. I think this is the main important part. We don't need to prohibit, we just need to advise. But I know that you work with sports, and sometimes we need to make the final decision. So I think that long QT type 3 is symptomatic with short QT. It's something that you can discuss. Long QT type 2 and 3, I don't feel comfortable. Literature say really mention about KT1, but KT2 is also very dangerous. We have like the hydration and disturbance in electrolytes. So I think I would not feel comfortable if the KT is over 500. I think the KTC is very important for this risk stratification.
But we should remember that when we measure the KTC, in these athletes, they usually are bradycardic.
Yes.
So the Blasé formula is not the best one to be used. And the general cardiologists usually do not know this.
Yes.
So it's very important to have this in mind. And according to the Ackerman group, and the American Association guidelines from 2015, they allow these guys to participate, taking care in long QT syndrome in water sports, number
Practice.
one. And usually they recommend intelligent defibrillator, DEA,
in the area.
AED in English, in the inside. And also, it's important to mention that even Olympic gold medals, as Dana Vollmer from United States, she has this syndrome, and she won a gold medal being a patient with long QT syndrome. I would like to ask our other speakers if they have any questions. Please be my guest. Dr. Laura, she's a cardiologist, a pediatric cardiologist, and in this population, especially in girls, the syndrome can be very that syndrome can be a little bit more dangerous. Is it right, Luciana?
Sorry, I think
is there any different in risk regarding age and gender?
Yes, specifically in long QT type 1, men younger, long QT type 2, a girl in this period of life, mainly during postpartum period.
Questions? Dr. Diego, any question? Dr. Jorge? Dr. Laura?
Hi, Luciana.
Hi, Diego.
Well, it's a pleasure. Really, your lecture was really very complete, clear, and wonderful. Yes.
Thank you.
I will turn on my camera. So the questions that I have is, do you consider the type of mutation in order to establish a relation between we can see prognosis, or try to approach the prognosis related to the kind of mutation, especially in long QT syndrome?
Yes, I have some controversial thinkings about that, because in the beginning I was very I was observing this non-POR mutation that we know that could increase risk, né? But after if we look to the Mazanti's work in long QT syndrome, what impacts me more is the penetrance. So I mean, sometimes we see variants that was supposed to be to care more to be more dangerous, but the penetrance is not so high. So I think if I have a patient with the positive phenotype, for that patient the penetrance was positive, and I can consider the mutation as an additional risk. I would not use the residue, the location as an something that would add me as a unique information to implant an ICD. But according with other features, mainly the EKT interval, then I would say, oh well, I was not so encouraged of putting this ICD, but this mutation is also related with more risk. Sometimes this feature can lead me to put an ICD. And then the shared decision, we can show it for the family also. But I really think that in my my daily practice, I don't remember many cases that this changed my idea. Of course, in KT3, we are always more aware, but the specific residue, I don't think that until now has changed my idea. How about you? Now I'm curious.
Uh, and depends. For example, it's true that you cannot take decision unless you have really a lot of information related with the specific variant. We don't. Of course, this is related with the casuistics and name, the number of patients. Suppose that you have a founder mutation, you have a lot of families. In that case, you have information. Yes, but this not. It's not usual to have a lot of information. We have many concepts, for example, of those mutations that produce truncation in tetrameric channels. Usually, the normal allele is the one expressed. So in that case, this variant usually are associated with not a lower penetrance, but maybe a late expression of disease of require another factors
Approach.
just to produce a more severe phenotypes. For example, that missense mutation, and we observe a group of mutation in the pore
Mhm.
of some channel that when we do the survival curves, considering a specific set of patients, we really observe a worse prognosis. But
Mhm.
we cannot yet, it's true, we cannot now translate it to the clinical practice to say, okay, I will decide to put a defibrillator in this patient because of this mutation. It's just complementary information that you use in a case that you have a doubt there, just to inform, to give the genetic counseling to the patient, to say, okay, will it be better to consider this,
Uh-huh.
maybe this approach, this device, etc.
Fantastic.
Perfect.
So both of you, you agree that the specific mutation will not be the reason to put an SED,
Mhm.
correct? So I have a few questions from the audience here. André Pacheco Silva, congrats you, Dr. Luciana. And his question is, how do you see, quick question, quick answer. How do you see the sympathetic thoracic denervation in long QT syndrome?
I think it's a good additional strategy. We here in Brazil we don't see people that say no to ICDs. It's interesting because outside Brazil it's common to say people that neglect the ICD. In Brazil, if you say to the patients that an ICD is necessary, an ICD is implanted. So we use only the sympathetic to additional antiadrenergic therapy in patients who are with the beta blocker therapy, the ICD, and they still have shock. So we use it more in CPVT, but in long QT type 1, I have only 2 patients. In long QT type 7, we have 2 patients. Now I know that for this QT7 patient, maybe it doesn't work so much, but for QT1 patient, we had some additional therapeutic complementation. So I think it's something to have in mind, but in our daily routine, it was not necessary all the time also.
Okay, there is another question here. I don't know the name of the person because in the recent publication, there are recommendations to test only 3 genes. The most common, KCNH2, KCNK1, and SEN5A, as they have the strongest evidence. Which type of panel do you use for testing of long QT syndrome?
I think this is not exactly the way you test, but the way you interpret. So now we don't have a panel with only 3 genes. Our commercial panel have all the genes. So I think I use the long QT in commercial tests. I will use long QT panel, and then we have 12 genes, 30 genes. So they test many genes, sometimes 30. So I need to interpret to use the KT1, 2, and 3 as the strongest gene. So it's difficult to use the guideline and select commercial panels because they don't talk to each other. So I just use I keep in mind that I need to be more to have more attention with these 3 genes or with the others when a syndromic feature is present.
Luciana, as a clinician and a person who is used to have a huge experience in these rare diseases, are you often see overlap syndromes with QT syndrome?
Yes, but only with QT3. So it's we have not so often. We have 1 patient with Brugada syndrome and QT in QT syndrome, and so we have many Brugada patients with slower conduction disease, but not requiring a pacemaker, but they have longer HV interval. They have some specific features like sinus bradycardia that it's inside the Brugada syndrome spectrum. So I think overlap syndrome is not frequent, but sometimes we can see that, especially with long QT syndrome. I think it's important to remember that when in long QT syndrome we needed to add a pharmacological choice because beta blocker is not so effective. We need to be careful in not using flecainide. There is no flecainide here in Brazil, but we could use propafenone. But then we need to think about that with the diagnosis with Brugada syndrome, because sometimes specifically in this residue 1784, 17 blah blah blah. Sometimes if we do propafenone, we can induce a VF because of the loss of function of sodium channels. So it's important to remember about overlap syndrome when doing pharmacological choices.
Okay. Dr. Luciana, Professor Luciana, thank you very, very much for your lecture and also for this very profitable discussion. It was lovely, and I would like to thank you very much to participate in the International Symposium of Cardiovascular Genetics. Thank you very, very much, Professor Luciana. And we'll have 1 or 2 minutes for an interval. And in 2 minutes, Professor Jorge Luis Rodrigues Garrido will be with us. Okay? Bye-bye.
Thank you all. Thank you for the questions. Thank you very much.
You're welcome. Bye-bye.
Un segundo entonces, un momento.
1 second. Okay. Hello, everybody. Now we'll go for the second lecture of this morning. And the professor that will hold the presentation is a friend of mine from Coruña, Spain. Professor Jorge Luis Rodriguez Garrido. He's a cardiology consultant with competency in electrophysiology and cardiac pacing in La Coruña University Hospital in Spain, in Galicia. He will talk about catecholaminergic polymorphic ventricular tachycardia and probably some features of both Parkinson-White, familial atrial fibrillation, and J-wave. But I know that he will focus his presentation in CPVT. Professor Jorge, be my guest, and thank you very much to be with me and with our audience from all over the world.
Okay, thank you. At first, thank you, Dr. Stein, for invitation and for giving me the miscellaneous syndromes. It's a pleasure for me to be able to talk. My presentation is first part, catecholaminergic polymorphic ventricular tachycardia, and then early repolarization syndrome. Okay, we are going to start with CPVT. CPVT is autosomic dominant disease. There are some genes recessives. We are going to see later genetic heterogeneous 6, 8, 10 genes. The main feature is ventricular arrhythmias during exercise or emotion. The symptoms can start at young age, and the EKG could be very, very normal. There are sometimes type 1, type 2, type 3. Dr. Stein loves Anderson-Tawil. There are the most form or type of CPVT is mutations in ryanodine receptor 2. Is autosomic dominante. There are other forms recessive, for example, mutations in calcium-sequestrin 2, in thionidine, in calmodin 1, calmodulin 2, calmodin 3. The problem here is, in the most of cases of the disease, is mutations in ryanodine receptor. So there is a gain of function mutation. So we have an huge calcium in reticulus endoplasmic and cytosol, and its problem is increased by adrenergic situation. So the clinical problem is, for example, it is a patient in my hospital, 58-year-old man, at rest, very normal EKG. 3 minutes on exercise, you can see bidirectional VT, or the axis in this beat is positive, and the next beat, the axis is negative. So this is diagnostic when you see bidirectional VT is diagnosis on exercise. So we have many risk factors for this disease: cardiac arrest prior to therapy, complexity of heutopy, the lack of beta blocker treatment, syncopal events. I think this disease is very different, for example, to Brugada syndrome. In Brugada syndrome, the ventricular arrhythmias is strange, but here the symptoms are very, very common. We can see over the years past, the ventricular arrhythmias are very frequent, mainly in men. The last guidelines this year, European guidelines, they say that CPVT is diagnosed when structurally normal hair, normal EKG, but in exercise you have bidirectional VT or polymorphic VT. Also, CPVT is diagnosis in patients who are carriers of a mutation in disease-causing genes. Genetic testing and genetic counsel are indications in patients with clinical suspicion or clinical diagnosis of CPVT. They show an exam very similar to my patient, bidirectional VT. You can see how the axis change, positive, and then the next bit is negative. So I propose this protocol for this treatment strategy. The first, lifestyle change, no exercise. The first level of treatment is beta blockers. The next flecainide, the next level left cardiac sympathetic denervation, and the last, of course, ICD. The guidelines for the treatment not change many years. Patient with CPVT, lifestyle changes, but all patients has to take beta blockers, asymptomatic and symptomatic patients. In aborted cardiac arrest, no ICD implantation, but if the patient continues with syncope with ventricular arrhythmias, you have to add flecainide of the cardiac sympathetic denervation. This slide is very important for me because one question: if our patients with the disease are safe just on beta blockers treatment, the answer is sometimes no. You can see here how patients on treatment with beta blockers, they continue having ventricular arrhythmias, syncope, or palpitation. So the American guidelines say flecainide can be useful addition to beta blockers in patients with a diagnosis of CPVT who experience recurrent syncope or polymorphic bidirectional VT while on beta blockers. There are some jobs about this, about flecainide therapy. One of them, for example, CPVT patients on flecainide, 29 patients, stable dose beta blockers, follow-up 20 months, one patient ICD shock in adherence to flecainide. The results, just 21 days, patients with no sustained VTs or sustained VTs become to isolated PVC or nothing. 5 years follow-up, the same. No sustained VT or couple or sustained VT transformed or become to nothing or just PVC. The international CPVT registries say over than 1,000 cases, asymptomatic patients, syncope patients, palpitation, aborted cardiac arrest. Patient characteristic, female 60%, ryanodine mutation 90%, median age at diagnosis 16. The most patients were symptomatic, so the result very similar. Symptom no sustained VT or sustained VT become or nothing on isolated PVC after flecainide with stress test. But the question is very similar. Our patients with CPVT are safe with flecainide plus beta blocker? The answer is very similar, sometimes no. This job, a randomized clinical trial, multi-center prospective trial, they wanted to include 60 patients with ICD. After 4 years, only 14 patients enrolled, but very strong antiarrhythmic effect in 13, but 2 patients received 3 shocks, both on flecainide. This job, no, they didn't see drug levels, no left cardiac sympathetic denervation. So my protocol is always this: lifestyle change, beta blockers, flecainide, left cardiac sympathetic denervation, and the last level ICD. Why? left cardiac sympathetic denervation. Increase defibrillation threshold, decrease repolarization in homogeneity, increase in efferent vagal nerve activity, no alpha-adrenergic stimulation, so a strongly antiarrhythmic efficacy. So the technique is very simple for thoracic surgeons. There are some jobs about this in New England. For example, this patient in my hospital is very similar from the first level. A stress test left cardiac sympathetic denervation. You can see bidirectional VT. After that, after treatment, 47 days on peak of exercise, no ventricular arrhythmias. You can see here on peak of exercise, a lot of ventricular ectopics, and then the ventricular ectopics decrease, and the heart rate was very similar to before left cardiac sympathetic denervation. Many publications about this, for example, the same results, 54 CPVT patients, sustained VT or many VTs left cardiac sympathetic, and then become just nothing or just isolated PVC. 3 or 4 slides from this syndrome, early repolarization syndrome. The diagnosis is aborted sudden cardiac death with J-point elevation over 1 millimeter and 2 adjacent inferior on and or lateral EKG leads. The problem here is a benign finding in the most causes pattern. Prevalence has been reported 6% in adults, is more frequency in males, in athletes. The problem here is early repolarization pattern is overrepresented in relatives of sudden cardiac death. Here, the genetic testing is the diagnostic yield of the genetic testing is low. There are some high-risk electrodynamic features, for example, dynamic change of ST segment, prominent J point elevation, plus down 2 millimeters, but the guidelines, the treatment is very inspecific. Abortic cardiac arrest is normal, high disimplantation, but patient with syncope, arrhythmic syncope and early repolarization pattern, you have to look if the patient has high-risk pattern, for example, plus than 2 millimeters, or changes in the ST elevation, or family history, or early repolarization pattern, at least one risk factor, loop recorded. Or if no risk factor, nothing. So the treatment is very inspecific. Okay, this is all. Muito obrigado.
Professor Jorginho, as I called you when we were together in Spain 7 years ago, Professor Jorge. Time's running fast, and we have plenty of time to discuss a little bit your presentation and also these different syndromes. And I would like to ask you, Jorge, as I called you always, what do you think about this CPVT syndrome and the Canary Island pedigree? We know that at this Spanish island, they went to the past and they have this foundation mutation. First one, since we are not with geneticists here and even cardiologists that deal with genetics, what is a foundation mutation and how they did this? Are you able to answer this question for us?
Which is the question?
The question is, you have an example in Spain, in Canary Island, with this this CPVT syndrome, and they went further past and looked for this foundation mutation in 200 years ago. How they did this, for me, is very impressive that they did this. And what is a foundation mutation is a very simple concept for us, but can you explain what happened with these guys?
Yeah, foundation mutation is a novel mutation for ryanodine receptor, just in local area. For example, this area in Spain is an island, so the communications are very bad. So it's very, 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 very specific in this area for this one. Your question is more genetic aspect. So
yes,
how radical mutation, or missense mutation, or French mutation.
No, my question is not exactly regarding the specific foundation mutation. My question is, do you have any idea how they went further 200 years ago to found this foundation mutation? How the scientists did this, studying the history of the island, and found a mutation that started 200 years ago. Understood?
They show that, for example, one family with 7 or 8 persons who die on exercise. They have a huge tree for.
Exactly.
Yes, it's a new many relatives for maybe 2 decades or something like that. They are looking in the past, but it's the same for anywhere. They saw ventricular arrhythmias, cardiac sudden death in relatives, in son, in father, in cousins. So they wanted to look the problem, and well, they have to put, or have to have an enormous pedigree for the family foundation.
Perfect. Last week we discussed during the Juan Pablo Shoa presentation, and also Dr. Peter van Tintelen presentation, a foundation mutation in phospholamban in Netherlands. But this one in ryanodine 2 from Canary Island is the oldest pedigree that I haven't seen. So it was very impressive for me when I was studying this with Diego, yourself, and other guys in Spain when I was in Spain. How they did, how they found the mutation going back 200 years. But I have another question, if you permit me. Professor Jorge, look, once I had a goalkeeper, professional goalkeeper, and this guy was doing the pre-participation screening every year, and everything was great, everything was set. But in the 6th time, when we put him in the treadmill and he started to run, we had a bidirectional arrhythmia. and then we diagnose catecholaminergic polymorphic ventricular tachycardia. So, do you think, and your practice, I am sure that tachycardia, polymorphic ventricular tachycardia, you will not will not find in the shopping center. It's something rare. But how do you handle with the exercise testing? The example that I'm saying and showing is something that it was very impressive for me as well. When you have a patient, how do you handle with the exercise testing to trigger the ventricular arrhythmia?
This disease is very impressive because you have you have to do several stress tests for the diagnosis. You can have a normal stress test, but the patient when at home he has symptoms or palpitation, and then when in your clinica the stress test was normal. In these cases, I think is better when you suspect maybe genetic testing, because it's difficult to do 6 or 5 stress tests in the same person.
Mm-hmm.
This is very difficult diagnosis when everything is normal. The patient has syncope on exercise, in everything is normal, stress test is normal. In several times you did. We are going to another stress test. Diagnosis is impressive. This is.
But we should remember that even when you have the phenotype, you have this bidirectional arrhythmia, palpitations, and so on. In 60% of the cases, the genetic testing will be accurate enough, and you have the result. But you can have a negative test, genetic testing, with the complete phenotype. So genetic test is not always positive, as even in Marfan syndrome, when you have 90% of accuracy for the genetic testing, and in Brugada syndrome, you have 30%. Dr. Diego, Dr. Luciana, Dr. Laura, do you have any question for Professor Jorge?
I want to complete something about the stress testing. I don't know if you agree. When you mention many tests, many negative tests, we feel that also. We see this also. But sometimes the patients start with monomorphic PVCs, and then going forward, they start with couple, and then they start with the polymorphic features. And many times when we receive a stress testing from other service, they stop the stress testing when they see the pairs and the PVCs, and we inside our hospital we used to make a protocol that we try to do the maximum test. And I think that when we do all the protocol every time, we can reproduce the arrhythmia every time. I don't know, I think your observation is very interesting, because of course I have less genetic testing than you, so I have more phenotyped people than you. I have our practice is with phenotype positive patients, very positive. So all the stress testing are very rich But sometimes when we also genotype, but the familiar screening in our daily routine is still scarce. The genetic screening, so we don't have this experiencing of making the testing only when genotype is positive. So we have a familiar screening, and then you take the phenotype positive, the genotype positive family members, and then you put in the stress test in the treadmill, and you don't observe such an arrhythmia, one because of the incomplete penetrance as well, but also because the expressivity. Because when we have a phenotype positive, less because of medication, all our stress testing and all of them are very positive. So I maybe it's like a bias selection, isn't it? What do you think?
No, I think what you say, Luciana, is very, very useful, very important. I remember we participate in one of the part of this work of the Canary Island with this founder mutation, and really, this gives us the opportunity to just to evaluate a very homogeneous population, because if you are talking on a population with the same, even the same mutation, the same molecular etiology. So I remember that what Fernando Van Wemmer observed in this paper was that some patients require up to 10 stress tests just to provide and to find. They found something like 72% of I don't know, the positive grade was about 72% of patients were diagnosed by stress tests, but they were looking only for the bidirectional tachycardia. So in that case, what about other type of arrhythmia that you just evaluate there? So this is a good example with a very uniform population. Even sometimes it will be very useful to evaluate what happened, what kind of arrhythmia they detect previously in this population.
You know, I just remember one case, a girl, she was discussed at our cardiology department meeting every Thursday. And then she went to the third or fourth exercise testing, and all of them were negative. Then myself and Dr. Anderson Donelli da Silveira, he was a resident at that time, we performed the fourth exercise testing. And then it happens exactly as Luciana mentioned. During the exercise testing, we have some ventricular PVCs, and then we did a maximal testing. And I remember that Dr. Anderson, he told me, no, it's another negative. And then at 4th minute of recovery, we had a huge bidirectional ventricular tachycardia. So it's important also to respect the recovery time of the exercise test, because if we are quick in doing the test, and also the protocol, people are doing, even nowadays, the Bruce protocol or the Elstad protocol, and I think they are dead. Even Dr. Bruce, Robert Bruce, 3 years before dying, his death, he said, I don't know how people are using Bruce protocol. So my practice, not only for this, but I do a REM protocol, but a speed REM protocol, trying to do a maximal stress testing. And this kind of test, I will not do in my office. I will do it at hospital. But I have another question for Jorge. It deals with a very rare entity. Is the early repolarization syndrome, especially the type 3, because there are types of the malignant early repolarization syndrome. I don't know, Jorge, if you are used to deal with these Hasegaer syndromes. And unfortunately, we had a girl, 19-year-old girl from one club from Brazil, and she, after the train, one day of light training, she collapsed, and she was resuscitated. Now she had an ICD. Also, the doctor who saved her life is here with us. This girl, she had a weird ECG, and I put my eyes on it, and I told my colleagues, I think it's early repolarization syndrome. Then we performed the genetic testing, and everything was completely normal. And we have a VUS in CACNA1C, the gene that is responsible for this type of early repolarization syndrome. We are talking about the rare of the rarity. What do you think about that? For me, seems to be a vulture. It's bad meat in the road, and probably is a vulture. It's not a cauliflower or a beautiful bird. What do you think about this, the VUS that happens in these rare syndromes and also in not so rare syndromes? How do you deal with this?
I think the key here in L repolarization pattern is identify the pattern, but the problem is in the repolarization is very dynamic in these patients. So we have to you can have a early repolarization in inferior leads today, and tomorrow maybe you don't have. So maybe in patient with ventricular arrhythmias or sudden cardiac death with in plus early repolarization pattern, you can say this a malignant pattern because we did a genetic testing and was positive or mutation in one gene, whatever. It is difficult the correlation between mutations and this repolarization pattern, I think. Sometimes we have many patients with, for example, you say athletes or Africans football players with anterior repolarization pattern, and everything is normal. It's difficult, in my opinion, the correlation between mutations and this disease.
Okay.
It's very difficult. I don't know.
No, it's difficult. Yeah, you're right. Okay. Thank you, Jorge. Dr. André Pacheco Silva, probably an arrhythmologist. Congrats, Professor Jorge. I have a patient with probable CPVT, birational VT at exercise test, but the ECG with preeminent U wave and long QU interval, and they suspect Anderson-Tawil syndrome, a very rare syndrome. We count in two hands how many patients had with Anderson-Tawil syndrome are in the world. And Dr. Pacheco wrote, we have a negative genetic test for both conditions, no dysmorphic features. We started beta blocker. Can you talk about this condition and advise what to do?
Yes. The treatment is very specific. Beta blockers, or you have to the follow-up in your clinic with stress tests on beta blockers, and then if the patient continues with symptoms, you have to add a flecainide or maybe ICD. Or the treatment is very similar for these syndromes. Is the same. It's the same if you know find any mutation on genetic testing. Is the same because the treatment is beta blockers, no exercise, flecainide or ICD.
But I think we need to. We are talking about very rare entities. Anderson Tawil is a very, very rare entity. But since Dr. Pacheco mentioned, we should remember that this disease, this syndrome, is the prognostic is not very good. So, do you put an ICD straight, Dr. Jorge, in this patient if you have a high suspicion that is Anderson Tawil?
I think yes. We put an ICD in 7-year-old female with ventricular arrhythmias the whole day. And we have maybe 3 appropriate scar, but it's difficult. I think yes. The ICD is indicated when you have ventricular arrhythmias on full dose on beta block.
Okay. I want to just to clarify something. VUS is a variant of insignificant VUS.
No clinical significance.
With an unknown significance. Thank you very much, Diego. You saved my life. Questions, please. Any other question for Professor Jorge?
I want to do one more, if I can.
Please, sure.
We also have that common question from families about sports activity, not athletes, I mean, but leisure activity. Can you hear me? When the family, because normally we do this diagnosis in the beginning of the first decade of life, so many families question us about sports activity at school. Of course, there is no consensus or guideline for that. But what is your practice? You just allow the children to do the laser activities, or you also make some recommendation for sports activity at school for the not competitive sport, but during classes? Do you recommend something more, or only restrict the intensity of the activity?
Yeah, of course. The competitive sport are excluded, of course, but they can realize sports, for example, cycling or swimming, but the level of the sport has to be very, very low.
So sometimes you wrote something to school, for example, to have that nice station.
Yes.
We must remember that these kids, they may have a long life. And if we prohibit them to make leisure sports, they will be obese, diabetics, dyslipidemic, stressed, and so on. So we must weight the risk of sudden death from the familial disease and the risk of being at risk of having an MI with 40 years of age. So it's very tough to decide because we don't know exactly what's the best approach. But I think we must be, we have to discuss with the parents. And in my experience, I try to allow them to do some exercise, but competitive sport, for sure. There are two diseases that I deal with a restrictive way. This one, CPVT, and the arrhythmogenic right ventricle dysplasia from the right and or left ventricle. These are diseases that I don't like to deal in my office of sports cardiology and exercise cardiology, because I must be the opposite as I always are being, proactive with exercise and sports. So it's tough. It's tough, and the studies probably will show in the future what is the right approach. But this is a very important question, Luciana, because when you have a kid with this, we must handle the responsibility of allow and not to allow to do this and that and that. And I don't know, it's difficult. What do you think, Diego?
I completely agree. And I remember in the consultation, usually you see dramatic histories there. Sometimes adolescents always play competitive sport. They don't understand what's just to play for leisure. So it's difficult to take the decision sometimes just to counsel. But of course you need to have really a very clear evidence that this variant of the genetic death of the disease really is predisposed the patient or this child just to the sudden death event, just to forbid really the practice of sport. If not, it's better sometimes to follow up in order to find any marker just to allow you to take this decision. It's very difficult. You have to face with the patient, and you have to face with the fathers of the patient.
Professor Laura is with us. She's a professor of pediatric cardiology at the University of California, San Francisco, for 15 years. And please give your opinion that is as an expert.
It's been a while. I have not practiced in 6 years. But no, I appreciate your dilemmas. It's very hard to put restrictions on people's quality of life. It's a difficult balance. I do not envy you having those discussions. But
okay.
Yeah.
Okay. At least one native speaker. we are doing this symposium in English. We have a Spanish, yes, an Argentinian, and two Brazilians, and now a native speaker. Great. So I have the last question for you, Jorge. Do you agree that there is a familial atrial fibrillation syndrome?
No, it doesn't exist. Atrial fibrillation. We didn't see atrial fibrillation familiar. In my opinion, when you have a young people with atrial fibrillation, you have to find, for example, another canalopathies, baby Bugadan syndrome, long QT syndrome. It's difficult to find atrial fibrillation familiar. You normally in your clinic you see many patients with atrial fibrillation familiar. I didn't see ever.
So Professor Jorge is introducing an interesting concept that atrial fibrillation is not the disease. Atrial fibrillation is a consequence of other diseases. What do you think about this, Professor Luciana, Diego, and Laura?
Yeah, in my experience, it's been a consequence of other pathophysiologies. But
This is a
you
very
all are
interesting.
the arrhythmogenic experts here.
Yeah, it's a very interesting concept that Georgie brought to us, because I've been reading some papers that they disagree with you, and they wrote something about familial atrial fibrillation. But Luciana, you are
Apologies.
you are this thing, the electricist of the heart. So, what do you think?
I agree with George. I think the main thing is to rule out the incipient cardiomyopathy, because sometimes we have laminopathy starting with atrial fibrillation, and this is there is a great prognostic value in understanding if this familiar atrial fibrillation is the start of a disease. So it's very interesting, because we have a paper in Frontiers that we said about 3 families that for 10 years they were long atrial fibrillation, and I think that's why the term long atrial fibrillation is discouraged by the guidelines nowadays. We don't need to talk about long atrial fibrillation, because in the majority of the time they have the families have another condition underlying the atrial fibrillation. And when we talk about the real long atrial fibrillation, this is a rare disease. I think it exists, but it's a rare disease. So we have atrial fibrillation with KCNK1 mutation, with SCN5A, the major genes for atrial fibrillation, familiar atrial fibrillation, but this is a rare disease. So we conducted a study at INCAR with 100 patients with long atrial fibrillation, and we found some KCNK1, SCN5A, but we also find this laminopathy. So as I think that the prognostic comes first, it's paramount to understand the underlying condition, and then your last diagnosis is long atrial fibrillation or familiar atrial fibrillation. This is my opinion.
Fantastic. So we can go ahead, and we'll have another 1 or 2 minutes for going to the toilet, or having a glass of water, and be with us, because in a few minutes we'll have Professor Diego Justiniani talking about something that is not so rare. Now we'll talk about something that can be more prevalent. In 1 minute, we'll be again with you. Okay. Hello, everyone. Welcome to the International Symposium of Cardiovascular Genetics. We are ready for our third presentation this morning. I'm very happy that the discussion and the lectures are being great. And I would like to say that the lectures are very important, but I think the main thing of this symposium is being the discussion, because we can talk with the experts and learn a lot with them. This is why we have 20 to 25 minutes to discuss. If we go to a congress everywhere, we'll have 5 minutes of discussion, sometimes no discussion. And this is the different thing. And I'm very happy that we are having amazing discussion. So now it's my pleasure to introduce Professor Diego Alonso Garcia Giustiniani. Diego is also my friend. He's from Argentina, Buenos Aires, but he's been in La Coruña, Spain for the last 12 years, Diego.
Yes, I have been there for about 30 years.
Yeah, for many years. He forgot how many years he's in Spain because he is old. And Professor Diego, he is International Cardiovascular Medical Affairs, Health in Coruña, Spain. And also he's head of the genetic area of early atherosclerosis, and also Health in Code scientific advisor of this company from Coruña, Spain. I can tell you that Professor Diego is one of the persons in the road that one of the best experts in this area of knowledge. I am quite sure that his presentation will be great, but the discussion, I'm sure that it will be fantastic. Professor Diego, be my guest as you were when we had lunch together in Coruña.
Well, thank you very much for your amazing presentation. It's clearly that you are a friend of mine.
Yes.
But okay, we have been really, I don't know, just working in this spectacular area, amazing area for many years. Okay, we are learning as everyone in this moment. My conflict of interest is clear, but I try to just to give you just a very general concept, a specific concept that I think are useful for a routinary clinical practice. And thanks for the audience to stay there, despite this. We have more than 2 hours or something like this. Well, lipids, dyslipidemia, specifically hypercholesterolemia, is clear that is one of the most important risk factors for the development of coronary heart disease. Almost 50% of the risk, the attributable risk for develop coronary heart disease is related with lipids. And several cohorts, the principal cohort, the framing heart studies, and the subsequent cohorts found that the heritability is really high. There's something there on the genes related with the disease. But what is this something that I'm talking about? One, we had to split the genetic cause in two groups. One of them is related with the monogenic cause of the disease. That is when a set of limited number of genes has a really largest effect that affect the pathway, the lipid pathway, and it generates usually determine very increased lipid levels and affect young individuals. But the other side, we have the polygenic cause of the disease, that is the typical hypercholesterolemia. In that case, we see in the medical consultation. Are common, the common form of the disease is captured now with modern cardiovascular polygenic risk score that are in the process of clinical validity, and also more specifically in some polygenic score validated for specifically for hypercholesterolemia. This usually this polygenic cause is caused for polymorphism, so the variant present in most of us in the general population, and the lipid levels are highly variable, maybe really large increase also. And when we are talking on genetics, well, what are we talking on? We're talking on a gene codified for a protein, specific protein, and this protein is participate in the very complex lipid pathway, and many of these proteins interact each other. And this protein may be structural proteins, maybe intracellular transportation protein, maybe receptor like the LDLR, that is a receptor, the most common, and enzymes. These genes of these proteins are captured by the polygenic, the one mentioned previously, this polygenic risk score. And this kind of score not only capture all the variant or polymorphism involved in lipid metabolism, but also involved in other pathways related with the cardiovascular, with atherosclerotic disease, maybe those related with vascular remodeling, blood pressure, neovascularization, etc. Another important concept is what we see in the labs when we ask for the lab is related with the type of lipoprotein. Lipids are transported by lipoprotein because the lipids are insoluble in the blood, so should be transported by lipoproteins, and the proportion of the lipids are different between them. For example, the LDL generally transport the majority of cholesterol, but by chylomicron usually transport triglycerides. So it depends on the defect, and the increase of the lipoprotein is what we will see in the clinical lab. Another important concept, as I mentioned previously, because of this complex pathway, several proteins maybe interact each other, and a defect in one gene, that is in the protein, could be manifest clinically. This is the classical Fredrickson classification of these lipidemias, can affect several genes, the same pathway, and produce a similar clinical phenotype. So that's the reason why it's important to evaluate panels. And when we are talking in general in medicine, but in lipids also. So let's talk on FH, familial hypercholesterolemia. This is one of the most, if not the more prevalent monogenic disease in the world. It depends of the cohort, 1 out of 100, but in some population, the north of Europe, maybe it reach a very greater prevalence in the general in the disease. And we are talking the general population, not hypercholesterolemic patients. So diagnosis is based on clinical and now genetic criteria. The one more used in the world are the Dutch Lipid Clinical Network criteria, and in the UK, the Simon-Broom criteria. Most of the clinical societies recommend the genetic studies. Then we will try to infer why. And one of the reasons is that this strategy has a high cost efficiency ratio. And pediatric patient usually is more with the one who more benefits for the genetic studies, and we will see why. First of all, this is a picture. This paper has, I think, 5 years, but it's really dramatic because this is, despite it's one of the most common monogenic disease in the world, is also highly underdiagnosed in the world generally. The two bars here represent the diagnosis of the patient. The blue bar and the middle represent diagnosis made only using the LDL or other clinical features, and the green bar represent all those made by genetic test. I will try to Okay, I think you are seeing the pointer here. And only Netherlands has almost all the population, the expected population diagnosis by clinic and genetics. In the rest of the world really is dramatic. In Spain, for example, that we use, where really the state pay for the genetic test, the diagnosis is only 30% and on gene only 20%. And there are many reasons, maybe those related with official policies, and maybe sometimes some doctors are reluctant just to ask for a genetic test, and now the cost dropped dramatically. It's not an expensive strategy to do that. So we can approach the patient using clinical criteria, it's true, but in that case you need to gather several information. You need, first of all, the patient need to have a very high level of LDL cholesterol. If and need clinical history, you need to get physical examination information. You have to know if detailed information on the family. Sometimes it's not so frequent. It's not so easy to find this information in the medical consultation because several features. But at least you will need a positive genetic test to confirm it's a genetic disease. So you need a genetic test. Is a logical thing about it. The Dutch Lipid Clinic Network, not used here in Spain, also include the family history, some physical examination criteria, and finally, the LDL, of course, and finally, you need to demonstrate and to be certain on the diagnosis by the molecular testing. Why? Because it provides you 8 points, and you need only one more point just to confirm the diagnosis of the disease. But here I put a warning message that it is supposed that just to confirm the relation of the mutation with the disease, you need to be very clear with the pathogenicity of the variant. The variant of no clinical significance, or the variant that if you don't know really there is a relation or association, you cannot consider it as a genetic cause of the disease. You have to explore in the family, do the co-segregation studies, etc., just to be clear that the mutation is related and associated with the disease. And what about the clinical examination? The physical signs usually are non-specific or are very infrequent. You had to be very experimented just to determine this. For example, the one located in the Achilles tendon may be more specific for FH, but in the rest of the body, usually the same as xanthelasma, usually very and non-specific. It's not useful to make a diagnosis unless it provides a lot of point in the score. The other part, the other concept is very important. There is a significant overlap if you only measure the LDL cholesterol. Here you can see the area under the curve. The overlapping is really important. Of course, the more cholesterol, the greatest possibility that you have an FH, and is reasonable. But sometimes your patient will be in this area and you will face an overlap, a dangerous overlap. And most important, look at this graph, especially here on the right, at the same LDL cholesterol level, it's not the same. The prognosis is not the same if you have an FH or you have a common hypercholesterolemia. Even with those values, very high values, and the hazard ratio in that case, the radio specifically, maybe the triple of in the case that you have an FH. I'm sorry. And this would reflect, for example, by that study, almost 9% of patients that were admitted in the coronary unit with premature coronary disease has a clear diagnosis made by genetics and clinical features of familial hypercholesterolemia. Really a huge proportion of patients considering a rare disease. Here you have the names and what is the definition of premature coronary diseases? Men below 55 years old and females below 65 years old. Maybe if you see patients, cardiologists, maybe you see one of them, and maybe this diagnosis was omit. And this happened just because of that, because the concept, the more important concept is the time of exposure is the main feature of the key point of this disease. It is supposed that the patient has elevated has cholesterol and acting and affecting the blood vessel from early stage in life. So for the same reason, look at this line here. It's like the patient is exposed to really dramatically increase in cholesterol. So at the age of 35, the coronary events start in this population. And the opposite, and people who develop an hypercholesterolemia later in life, the typical one you see in the medical consultation, this disease appear beyond the 55 years old. Well, let's see what happens if you start treatment, is the red line, early in life in pediatric patient with low dose of the statin, then you modify and you change for high dose of statins when the patient has more than 18 years old. So the curve go by this side is quite approach to the same risk of the general population with hypercholesterolemia. And this is a very important concept. You need an early diagnosis of the patient and to start early with the treatment. So if you do that, you will avoid several and many cardiac events, and you save money doing that. The people in UK using the Simon Broom just detect that. In patients, follow up from the 20 years old and treat from this age, the savings is really the greatest. Why? Because you avoid in this population this amount of event. 30 years following patient and treat patient, you avoid the majority of event, 67 cardiac infarction considering every 100 of individual tested. So let's change to another important concept that I want to give you, is that not all mutations behave the same. I think we discussed it previously. This is the LDL receptor gene. Here you have a lot of segments that participate in different process or functions of the protein. For example, those mutation located in the recycling transport usually respond better to statins and are related with a really lower or more benign phenotype. This work is made by Raúl Santos, is from the hospital I would say Lucia, but okay, it's not Lucia.
São Paulo.
Yes, it's from the INCOR, Raúl Santos, yes. And he published a very interesting paper when he detected those patients with a null mutation, those mutations that produce a truncation, really affect the synthesis of protein, respond worse to the statin. So only 22% of the patients reach the target, the 3.4 millimole deciliters, just to avoid events. And conversely, the patient without mutations, the typical that you see in the medical consultation, respond better, 47% reach. So in that patients and the patient with null mutation, maybe you will need agreed doses really of statins to combine treatment, or even in this patient you'll be able to indicate the PCSK9 inhibitors to treat the disease, because the low response. So what is important by the other side to ask for basic, to request basic or food panels. This is due to there is several differential diagnoses in FH. So the family combined hyperlipidemia, the type hyperlipidemia, the one that you see in the consultation, is very, very prevalent, but sometimes may confuse some patient with hypercholesterolemia. Familial hypercholesterolemia could have the triglycerides also increase. That is the definition of the combined hyperlipidemia, and by another pathway, not the same. And this combination made you confuse on the diagnosis. The hepatic lipase deficiency is another diagnosis, and this one, the lysosomal acid lipase deficiency, is very severe cause of hypercholesterolemia. We see one last week here in our lab. This patient usually do not respond to or respond really very bad to lipid lowering drugs, and there is a specific enzyme replacement treatment for this kind of patients. It's important to detect. It's a recessive disease. It's very rare, but you can find in your lab sometimes. Cystostrirolemia usually may be associated with hypercholesterolemia. Usually, it's more associated with the abnormal the normal metabolism on the plant sterol. With the humans, we don't use the sterol of the plants, but and sometimes due to the effect they increase and produce xanthomas, xanthellamas, and sometimes may predispose to cardiovascular disease also. And it's important to detect because it's treated with diet just to avoid this kind of plants. And the polygenic hypercholesterolemia is another chapter that we will discuss in a few minutes later. Polygenic FH really now, where most of the centers are starting to study this possibility, and the most validated score now involve 12 polymorphisms that are related and participate in the lipid pathway. So the effect is really modest or slight on each of these effects, but the sum of all of the sum of all of them may determine, together with non-genetic factor, and really a great level and very increased level of cholesterol. But the prognosis is different in that case. And as I present in the previous presentation, unless the cholesterol is really very increased, prognosis is different in terms of cardiovascular events. And importantly, it's not transmit in the family with the FH pattern, autosomal dominant pattern, where 50% of relatives may be affected. In that case, it's not that case, and it's useful to know it just to give a correct genetic counseling to the family. And importantly, also, is more than 80% of patients that are phenotype positive, fulfill criteria, maybe clinical criteria, but genotype negative, will have a polygenic cause of disease that you can detect. So, what about the risk associated with the polygenic form of FH? One side, the risk is according to the tile here, and usually the score is organized, is segmented in deciles, yes, and there's a clear correlation on the risk of coronary events related to the decile. But what about those patients, the comparison in patients with polygenic disease, and despite with those with monogenic disease, or patients without mutation identified only with decreased LDL? And also there is a grade that we can see in the survival curve here. In the light blue line, you see patients only with increased cholesterol, and the dark blue line here, or gray, I don't know, it depends, do you see on the screen, the prognosis is worse. And in an intermediate point, you'll see the polygenic risk. So it's important to determine because there is a risk in the middle. Unless the cholesterol level between the three groups maybe it's similar. and this is important. I reinforce this concept. So what about clinical recommendation? This is one of them. Is one of the authors that propose this score. And importantly, I like you to focus on this part. This is a patient diagnosis with monogenic disease with a really very increased risk. The same happens with patient with the polygenic, the same behavior or conduct may be taken with those patient with a high decile of cholesterol associated with the polygenic FH. In that case, if the score is beyond the egg decile here, it's important to take a very aggressive treatment on this patient, despite you did not identify the genetic cause of the disease because of the risk tag present previously. And okay, just a couple of explanation of another form of dyslipidemias, or at least the more common that you will face in your consult. One of them is the FCAs of familial chylomicronemia syndrome. This disease usually is associated with very high increase of triglycerides. There are patients with, for example, believe me, 400,000. Sorry, yes, 40,000. Sorry, not so increase. Milligram deciliters of triglycerides. That is really increased. The typical is 6,000 patients, 6,000 milligram per deciliter of cholesterol, of triglycerides, sorry. And this is due to the defect in the metabolism of chylomicrons. This patient usually, remember that chylomicrons usually contain triglycerides. Yes. So the main feature of this patient is the development of pancreatitis, and the pancreatitis of this patient usually has a worse prognosis, high mortality than patient of pancreatitis of another etiology. That is important because the patient need to be treated for aggressively just to avoid death due to pancreatitis. This is rare, but cardiovascular heart disease is not observed in this population. Finally, you have another just forgotten dyslipidemia, that is like hypobeta-lipoproteinemia. That patient had very low levels of LDL cholesterol, triglycerides usually. So not always to have very low cholesterol it's good. In that case, is really maybe bad. Why? Because usually the reason of this decrease, sorry, is the increase of the VLDL lipoproteins inside the liver. And what is happening is a non-alcoholic hepatic steatosis, fibrosis, cirrhosis, and liver cancer. And we received some cases with liver cancer related with very low levels of cholesterol. In the case that the truncation of the defect affect all the ApoB protein, this is ApoB100, this is ApoB48, the other part of the genes. Additionally, the patient with a malabsorption and a deficit of soluble vitamin E and A, and need predispose to the patient to the psychiatric disorders, neurological disorders, ataxia, dysalgia, and hyperreflexia. So, as a final message, it's clear that it's important to define very well the pathogenicity of the variant because it's used as a diagnosis criteria. So the same disease can be caused for mutation of different genes. So it's important to know all the pathway and to explain the increase in the analytic in the analysis in the lab related with this patient. So want to perform the genetic test. In the case of familial FH, familial hypercholesterolemia, the sooner that you want, because those pediatric patients need to start treatment early in life, just to avoid events. Sometimes knowing the details of the mutation, as I present previously, is important just to determine the failure and response of the treatment. Maybe it had an explanation in the case of truncation in the LDR receptor. And the addition of this polygenic risk, especially of hypercholesterolemia, may be useful because it has been very well demonstrated that this other variant can act modifiers, can modify the phenotypic expression, and the risks may be different in carriers, not only of the genetic variant, but also these other polymorphisms associated that modify the lipid level, the lipid pathway, specifically the pathway. So, okay, thank you very much.
Okay, Professor Diego Alonso Garcia, thank you very, very much for your not only great, but also beautiful presentation. As I mentioned before, you are an expert in this area of knowledge. And I think that we have time for a nice discussion. And I want to ask you some questions. We are dealing with familiar hypercholesterolemia. This is a difficult name to say,
Yes.
especially in English. But this disease, the prevalence is not low. Is in some European populations we have 1 to 250, and generally speaking, 1 to 500. This reminds me hypertrophic cardiomyopathy, another disease, another familial disease. And regarding this disease or this syndrome, whatever, we have, for example, in the male gender, if they are less than 50 years of age and they had an MI, for example, if you perform a genetic testing and you find an LDL receptor gene, a mutation in this gene, the risk for another event or even for the family increase 4 times. If you have genetic testing and you got an APO5, your triglycerides will increase. And the risk will also increase for 3 times more or less. At least we wrote this in our paper. So I think I am right. What do you think about early atherosclerotic disease and performing a genetic test? When I was in Spain with you, I told Lorenzo Monserrat Iglesias, the guy the doctor who was receiving me over there, I told him, I think the future in terms of genetics is dyslipidemia. What do you think?
Well, what about the early diagnosis? Several countries are now changing they are doing something very, very interesting because they are taking profit of the vaccine programs in pediatric patients and just take a blood sample there and analyze lipid levels, and even if it detect in pediatric patient, I didn't say in my presentation, but in pediatric patient, it is require lower levels of cholesterol just to make a diagnosis, because you suppose it's not affected by external factor, diet, something like this in this patient. So they take profit of this program, vaccination programs, and in this opportunity, they test for LDL, and if they identify a possible FH, they perform genetic tests in the pediatric patient as the proband, as the index case. Then they confirm the findings with the fathers. Just they try to see co-segregation in the fathers. It's the opposite concept. Why? Because this is an important population. You have to detect the disease there in this moment.
Can I ask something? So, congratulations for your wonderful presentation. So, do you think probably from when you do the familiar screening since this age? If, for example, if you have already this family diagnostic, at what age do you recommend to make the genetic testing?
At what age? This is discussed because it's related. You can test the patient even at 2 years old. Yes, there's no problem because the mutation is present there. The question more sensitive here is when to start treatment in this patient, because unfortunately most of the drugs usually in the market are not tested in patients below the 18 years old because it's an exclusion criteria. Some of them, I think, pitavastatin have been tested in pediatric patients. So one of the recommendations is to start with. This is a reason why I think I put in one of the slide is to start with a low dose of statin. Why? Because you don't know the possible adverse event in this population, and of course phase 4 study and just to evaluate what happened in registries or something like this. I don't know option. But I think it's a good policy to start with very, very low dose until the patient has 18 years old and can start the full dose. But the earlier you diagnose the disease, you're gaining years and the risk of this patient.
Professor Laura, any comments? We can hear you. This was the main sentence during the pandemic. We can hear you.
No, this is absolutely fascinating. Thank you. I remember during training seeing a 12-year-old with familial homozygous hypercholesterolemia. It is a severe disease. And although in pediatrics we've started screening for cholesterol, there's never really been much discussion about how to address an emerging phenotype. So I think having the benefit of your genetic screening and kind of research going forward on the natural history will be incredibly helpful for a major problem.
Diego, any comments regarding the Dutch lipid criteria and the Simon Broom criteria? I wonder, it's a question. Clinics, so the number and some phenotypic features plus genetic defines the diagnosis.
If you
have the clinic,
yes,
and you perform genetic testing and it's positive, this define the diagnosis?
Yes, definitely. Usually, in fact, with the Simon Broom and the Dutch lipid criteria, you can reach diagnosis without genetics, but it's very difficult just to find, just to gather all the information required to make clinical diagnosis. So sometimes you delay a lot of time. So you had to ask for example, for familial antecedent to look the level of cholesterol of your father, of your aunt, of not your aunt, but maybe first degree, maybe second degree relatives. That when you finally gather all this information, you waste time. So now it's very cheap to do a genetic test all around the world. In this disease, maybe for cardiomyopathy, it's more expensive, but for hyperlipidemia, usually many of the hospitals around the world have the analyze inside the hospitals the levels of cholesterol, and the same with LPA. LPA is the same. Is another marker, important marker I didn't mention because of the time that you can perform in your hospital. So in that case, it's important just to lose to not to be fair and reluctant, and to just to be confident with the diagnosis. Okay, to say identify the variant. The variant is clearly related with the disease. and be performant as early as you can, because you need it. Finally, you need it to just to confirm, to get the point you need for diagnosis.
I have another question for you. I remember at least 5 different genes. The ApoB gene is dominant. The PCSK9 is dominant. Also, the LDLR is dominant. Then you have some recessive LRP1 gene. So this whole bunch of genes are in the panel. Do you think we'll find other genes in the future?
This is a difficult question, because the genetic study started in 1993, too many years ago, and now there's nothing new. So I think many of the effort are pointed there to the polygenic form of the disease, because this is a reason. I suspect that in Brugadas the same happened. This is a great, I don't know. There's a lot of phenotype there, and you are seeing, unfortunately, you are seeing a lab marker, the LDL level. But what about the molecular cause? The molecular cause now, I think we had to stop thinking on purely monogenic disease for every disease. If there you identify, maybe it will change this concept. You identify a variant with a large effect and several other variants with oligenic or lower effect, and together they participate to determine you the phenotype that depends of the cutoff when you define the phenotype. So there are a lot of variables. It will change. Maybe in the next year, all the concepts will change definitely.
Professor, before opening questions for the audience, and we have 2, I just have another one that I think it's important, and this is a clinical question. Sometimes we have in our patients, for example, someone with 104 HDL, and this person is atherosclerotic, completely atherosclerotic. What happened with HDL that do not protect us as usually it protects us? Are there any gene that work against us, that our HDL is very, very high, that you seems to be immortal, but actually you are very mortal?
Well, there is a very rare cause. We identify a patient with an alpha lipoproteinemia, very, very increased HDL levels, but the problem is this HDL is not useful. So you have different types of HDL. HDL, small, dense, several size of the particle, but some kinds of this HDL, you see, you cannot detect what time has the patient unless you do a very specific test. Maybe there in the States, Professor Schaffer, yes, they do this kind of test, and I don't remember I think he's in Connecticut in one of these hospitals, and you can have an hyperlipidemia, but unuseful. So and the reverse transport of cholesterol is not performed unless you have a great increase of this protein. This is a specific disease, very, very rare, very difficult to find patient.
Okay. Gabriel Carvalho, actually, he's he's a physical education teacher, and he's my master's student. He asked a very, I will not say weird, but I will say, I don't know, but which is the relationship between the telomere length and telomerase enzyme with dyslipidemia? Diego, do you know something concrete about this in the literature?
Honestly, not. because it's related with aging. With aging, I know that it's a relation, but I didn't notice. Maybe we can. I never heard of this relation. What?
Okay.
But
Uh,
I never heard. Maybe it exists.
Maybe we can study this, and as Elizabeth Blackburn, we can win the Nobel Prize. Next question is: do you know something about the role of microRNA in the pathogenesis of familial and polygenic dyslipidemia? Glauber Diaz is making this question.
No, in relation with polygenic, but usually in polygenic dyslipidemia, and in the polygenic cardiovascular risk, that is not exactly polygenic dyslipidemia, although this PRS polygenic risk score captures some variant. Um, they usually detect nuclear variants, variant located in the gene, no regulatory variant of microRNA. MicroRNA is useful for the treatment or in process of research for treatment, just to cell silence genes, for example. But I'm sure that there's a lot of theories and hypotheses on the regulatory roles of this kind of DNA in the development, but there is not a clear clinical now, for example, clinical association just to respond to the question. To say, okay, there is clinical evidence. No,
Okay.
or at least I don't know if it's a
To,
clinical evidence.
Two very difficult questions.
Mm.
Professor Laura, Professor Jorge, Professor Luciana, do you have any question for Diego? No. I have another question, Diego.
Mm.
We didn't mention, we didn't deal with this very often, at least here, but I am an enthusiastic of pharmacogenomics. And even with some other colleagues, I wrote a paper in Artigos Brasileiros de Cardiologia, a review paper for sure. And one guy from Health and Code, he was in the paper as well. My question is, in cardiology, we had in New England and other high standard cardiological journals some research regarding pharmacogenomics and clopidogrel and Marcomar, these drugs that are being still substituted by other more modern drugs as the NOx and Prasugrel, Ticagrelor, that are not related with the pharmacogenomics. But we, yes, can have in the dyslipidemia area something with pharmacogenomics. What is? When you are on a statin, one, at least in my practice for sure, in the literature, 1 to 10 or 1 to 15 who are on different statins, they have myalgia or myalgia. What do you think between the relationship to perform a pharmacogenomic study in these guys to see if there is something in their genes or in their polymorphism that can impact in this that is very serious?
Yes, we offer this panel in that patient, and sometimes you had two options there, just to demonstrate if the patient has the adverse event, the statin-induced myopathy. That is the one that we measure, or most of the labs measure, is related with the sign of the patient. Late, read the the paper, the prospect of the drug, and then present the adverse event, that the usual are really there a proof. Pharmacogenetics, far as I know, test pharmacokinetic part, the pharmacokinetic part of the problem, not the pharmacodynamic part. So in that case, you test there if the patient has now normal metabolism that produce an increase of the drug in the muscle and the blood. Just to predict, it's a predictive test. It's a predict can present the value. For example, in the SELCO1B1, SCLOB1
Yeah, exactly.
variants, complicated name of the gene, 18% of the patient with the homozygous mutation, the valine 164 variant, 18% of the patient would present the event in the period of 5 years. So there you have a clear evidence published in New England Journal of Medicine. If you detect this variant, the patient, and you detect and the patient present the death event, surely is related to the drug. So in that case, you recommend just to change the prescription for another drug that is metabolized in another pathway, maybe by the liver or not by kidneys or something like this.
Perfect, Diego. The problem is inclisiran and also the inhibitors of the PSC.
Mm.
I don't know how to say in English.
PCSK9.
These, yeah,
PCSK9.
these drugs, they are very expensive over here in Brazil.
Yes.
So this is a problem, but we can switch one statin to another one. We can
Yes.
try different
Yes. The
different
problem.
doses.
No, no, I understand perfectly. Usually the criteria, it depends of the government when to allow to treat the patient because, as you say, it's very expensive drug. It depends on the country. In Spain, the social security pays for the treatment, so they require that you be sure that the patient had clearly an adverse event related with the drug. So you have to demonstrate it. If you demonstrate it, okay, you're allowed to change and to use this drug. The other option is a patient that require really high doses of a statin. Even if you combine, you don't reach the target that you mentioned, 3.9 millimole deciliters, to speak internationally. So in that case, okay, the only thing you can do is just to add another new drug, maybe add, not replace, to add a PCSK9 inhibitor or to test to start with it. But you need to unfortunately, the pharmacogenetic now is not included in the program just to take this decision. Yes, but you have evidence. You have evidence. You can present it as as an evidence to say, okay, this is clear. The variant is there, and the patient has the signs clearly, and I quit the medication, and the signs stop. Okay, what else do you need? I had to change.
I decided just now that I will move to Spain again, and because I have pain with this, every statin and is painful and very stressful. But
Yes.
okay, it's 11:14 in Brazil. I would like to really thank you for the
Welcome.
presentation. The discussion was also great. And I would like to say something very serious after your presentation. Right now, we are all Aussies, Australians. Go Australia, go Australia.
No.
And I'm saying this because they will play against Argentina. Diego, thank you very much. We'll have a
Welcome.
break, 1 or 2 minutes before Professor Laura will give us the last lecture, a very interesting and I think different lecture because we'll be on the edge. Okay? Be with us in 1 or 2 minutes. Thank you very much. Just
You're
a second.
welcome.
So, so now we are going to the last presentation that I'm very anxious to see, because the subject is something new from everybody all over the world, that it's gene therapy in some diseases. Previously, Professor Natalia Patterson-Sonicheva, that is unfortunately a little bit ill. She's okay, but she was unable to be with us, and she just suggests that Professor Laura Robertson, so we changed Patterson for Robertson, to give the lecture in her place. And Professor Laura Robertson was trained at Johns Hopkins. She's a professor of pediatric cardiology at UCSF, University of California, San Francisco. She worked for 15 years over there, and now she's developing cardiomyopathy drugs she's developing at Myocardia Kinetics, and now she's working on gene therapy at another Bay Area, San Francisco-based company called Tenaya Therapeutics. So Professor Laura, she is working with a top-notch issue, and she will give us in the next 30, 35, whatever minutes her lecture, and then the discussion. Be my guest, Professor. Thank you very much for substituting Natalia, and I'm very, very thankful for Natalia's indication and for you to be with us. Please be my guest.
Well, thank you. I'm very honored to be part of this group. I'm learning so much this morning. I'm here to substitute for Dr. Patterson to talk about our gene therapy research as another potential approach to treating cardiomyopathies. As Ricardo mentioned, I am an employee of Tenaya Therapeutics. This company was founded by two molecular cardiologists, Deepak Srivastava and Eric Olson, with the idea in mind that heart disease has not been approached in the way perhaps oncology diseases have, where the oncologists are very good at identifying genetic markers and metabolic pathways and targeting treatments. We haven't advanced that way in heart diseases. So the company is research focused and trying to bring sort of any sorts of new directed mechanistic therapies to different heart diseases. And to that end, we are also focusing one part of our research on genetic cardiomyopathies. Our first two projects are in hypertrophic cardiomyopathy and PKP2 arrhythmogenic RV dysplasia. So we're trying to leverage all that we are learning in genetics to develop these very targeted treatments. And so today I will cover that briefly and tell you about what an AAV adenovirus-based gene replacement therapy kind of looks like. We're barely getting to clinic right now. So as I practiced pediatric cardiology for nearly 20 years, I spent a lot of time taking care of children with cardiomyopathies and heart failure. This is a family with a dilated cardiomyopathy in the family. They have 5 children. Among the 5 children, they've had 4 transplants. This oldest child, the daughter, has had 2 transplants. The next daughter has had a transplant recently, and the youngest brother, his first transplant. I've spent my career treating symptoms, and then, in some cases, patients would require a transplant when that is available and possible. It's, a temporary cure, but it is not a good solution. So I'm really motivated to find something that proves to be more productive in the long run to treat diseases. So again, as we're kind of thinking about how we think about heart disease treatments, we're trying to think a little bit more precisely, looking at mechanism of action or underlying genetics. So right now, we've had great advances in cardiovascular genetic testing, wonderful panels looking at channelopathies and cardiomyopathies. So we can identify family members, help risk stratify, predict potential treatments or need for implantable defibrillators going forward in time. But we're not really changing the course of the disease. So to that end, we've been looking now in the company at what other ways can we address certain kinds of mutations in cardiomyopathies. Cardiologists are wonderful at describing what a cardiomyopathy looks like. You can look at the echo or the cath and say, it's dilated, hypertrophic, non-compaction. But again, that doesn't really inform a targeted treatment. So the advent of genetic testing has been very helpful, and we can now at least say what the underlying mechanism is and help predict for families what may come in the future. But again, not quite to the treatment level. But the genetic testing has really transformed our ability to talk to patients about how their lives might be and what we might be able to offer them. The testing validity has increased, and the utility is good, especially for the risk management of sudden cardiac death and need for an ICD. So we tonight are focused primarily on one of the most common hypertrophic cardiomyopathy genes, the myosin binding protein C3, MyBPC3. It's the most common genetic cause of HCM. It is a loss of function mutation, so that people who are lacking a normal copy of the gene do not produce sufficient myosin binding protein. So this loss of function mutation makes it an ideal candidate to replace that dysfunctional gene. And we do know from all this genetic testing research that people with sarcomere protein mutations definitely have increased risk of malignant events over the course of their lifetimes. And you can see here, as you're looking at kind of HCM genes and kind of their expression over the age range, that there is a group here. Doesn't really show the pediatric patients, but the shared data does show kind of the younger group who will have significantly increased mortality, usually due to arrhythmic events in the younger and the older age groups. So we think there is an opportunity to hopefully change the course of this disease over time. So I will focus today on what the kind of gene therapy options might be, and then talk a little more specifically about the adenovirus group. So the gene therapy goals are, again, what is the underlying cause of this disease and how do we target that? Much in the way the oncologists will tailor their therapies for different tumors. We want to modify the course of the disease, ideally to either eventually prevent its manifestation or to reverse the condition once it has manifested. Ideally, this should be a single one-time dose that has a long-lasting, durable response over the course of time. The advantage of gene therapy in cardiac diseases is that after the first week of life, cardiomyocytes do not divide. There's a stable number of cardiomyocytes. So if you're able to modify the genetic makeup in the cardiomyocyte, you have high potential for a durable effect. And it's very important, as you go through clinical trials, that yes, you can replace the protein, but has this made a difference for the patients? Are they having meaningful improvements in their heart rhythms, their function, their symptoms, and very, very importantly, their quality of life? So when we're looking at types of gene therapy, there are kind of two basic categories, one the DNA level, the other at the RNA level. Gene replacement therapy, which I will be calling gene therapy later here, just as a generic term, aims to use a adenovirus to introduce a new normal copy of a gene. It's inserted into the cardiomyocytes and replaces the function of the mutated gene, and thereby producing new protein and hopefully changing the course of that disease. There are other forms of gene editing, CRISPR, and other techniques that are used to remove the mutated gene and edit with the new copy of the mutated gene. And then lastly, there's transcription level therapies that operate at the mRNA level. So, but for the purposes of this talk, we will be discussing sort of the gene replacement. So there are many different ways to introduce a new sort of healthy copy of the mutated gene. Two major classes are different viral vectors, DNA and RNA viruses. And then there are also some non-viral vectors, sort of polymers and different liposome-based therapies, all of which aim to deliver that new gene copy. But today we're talking about adeno-associated viruses. Sort of looking broadly, over the last 15 years, there have been a increasing number of trials using adeno-associated virus-based gene therapies. They've primarily been in other disease states, different metabolic disorders, ophthalmologic. The sort of most significant one that I've seen recently is Zolgensma, which is for spinal muscular atrophy, in which infants with homozygous state die of respiratory failure within the first few months of life. And the AAV therapy for that has reversed that condition. There are two new gene therapies recently approved in hemophilia. So far, none have been approved or actually tried for cardiac indications, although there is one we'll be talking about shortly through Rocket Pharma, where they are testing a gene therapy in Danon disease and cardiomyopathy. So that will be the first cardiovascular indication. So what is recombinant AAV therapy? So the key piece of this gene therapy is the delivery vehicle. So this big icosahedron here, this capsid is a sort of recombinant adeno-associated virus into which you insert a new copy of the gene. This new copy here in blue kind of comes with a promoter that will help the gene be transcribed in the new cell. The transgene, the one that we wish to replace, and then there's also a signal attached to it that helps the transcription factors. The viral capsid here is of a certain size and can only fit a gene that is less than 4.7 kilobytes. So we are limited at the moment with this particular delivery system to certain genes. And that is one of the reasons we're focusing on the myosin binding protein C3, because it fits. Myosin heavy chain does not. So how do you put one of these together? I think there's a lot of magic in the laboratory and our manufacturing area that I'm not entirely cognizant of, but here's the general concept. The wild type AAV vectors are sort of denatured. Their capsid proteins and genes are removed. So then they are called recombinant AAVs, into which the lab will insert the cardioselective promoter, the transgene of interest here. In this case, for us, it's the myosin binding protein C3. For Rocket, it's the Danon disease LAMP2 gene. And then there's the terminator clause here that helps promote the mRNA transcription. So that is inserted into this new capsid and becomes your AAV vector with the delivery of this new gene. The viral vectors are suspended in a delivery fluid. They're given intravenously, ideally as a one-time infusion. And then the promoter will hopefully go straight to the cardiomyocyte and deliver the new working copy of the gene to the cardiomyocyte. And then eventually, through transcribing that gene and creation of the missing protein, restore function to the cardiomyocytes and hopefully cause sort of transformation of the heart morphologically and improve function overall. So once that vector is delivered to the cardiomyocyte here in step 1, it's pulled into the cardiomyocyte and to an endosome, which breaks down. At step 3, this therapeutic DNA then will be brought into the nucleus. And the really important concept here is number 4. Rather than being incorporated directly into the patient's DNA, it remains as a separate episome, a little circularized DNA form, separate from that nuclear DNA, so that this episome only will transcribe for the protein of interest and only continue to do that independent of the patient's genome. This means that you cannot transmit this new gene to your offspring. So it's a one-time, one-patient treatment. So the very first genetic cardiomyopathy that has been addressed with an AAV gene therapy is by Rocket Pharma. This was developed by Eric Adler at University of California, San Diego. And he has developed this AAV9 vector to deliver the LAMP2 gene for the Danon disease, which is characterized here on the left. You can see the pathology slides of kind of a hypertrophic, dilated cardiomyopathy. There are many vacuoles in the specimen here due to the absence of the LAMP2 protein. So it's an X-linked disease. So in males, it manifests in early childhood with death occurring usually in the early 20s. Female carriers will develop cardiomyopathy later in life since they are only heterozygotes. But for this group of patients who either die or go to transplant within ages 20 to 25, this is seemed to be an urgent indication and potential to study how a protein replacement could occur in a cardiomyopathy and potentially change the course of the disease. So as they're looking kind of at the natural history of the X-linked disease in the boys, diagnosis usually occurs sometime around age 10 to 13 with pretty significant decline by age 15 to 17. So they decided to optimize their early phase 1 treatment initially in sort of the older group, kind of the 17 to 21-year-olds, and then also in a pediatric group after that were boys who were like 10 and 13. So the hope was if you were able to replace the protein at that stage that you could stabilize or potentially improve the course of the cardiomyopathy and prevent progression to end-stage cardiomyopathy and or the transplant. The group uses an AAV9 vector. This is a form of adenovirus that is has an affinity for the heart. The different types of adenoviruses have affinities for different types of tissue. AAV9 is probably the best one for cardiac indications. So they've inserted a LAMP2 gene into an AAV9 vector, given it IV. And these are their recent data that they presented at a heart failure conference in Washington 2 months ago. And these are the two patients who are the younger of the two. They were 11 and 12 years old. And so the study had a number of measures to look at potential outcomes. This is only phase 1B, so there were a total of 5 patients in this study. But when you're looking at the two younger children, on cardiac biopsy, they had a baseline that showed quite low percentage of protein, about 0.5% in the child on the left and 2% on the child on the right. And then when they biopsied again 9 months later, there was expression of protein up to 21 and 35% respectively. So how did this, so you can show that the gene had been delivered, they had evidence of expression of the new protein, but also looking at measures of cardiac biomarkers, troponin and BNP levels decreased in this time period. The boys also were taking the cardiac Kansas City cardiomyopathy questionnaire, so to look at kind of their symptom burden and quality of life. Their scores definitely increased over this period of time. Sort of 80 is a score that would be kind of normal, so they went from definitely abnormal to more of the normal range. Their New York Heart Association class also improved over time. So these are early results. These are just coming out, and we will see kind of how things progress over the next few years. But it's a very encouraging result to see that the protein was taken in and, or the new gene was taken in and new protein is being produced. So we are now following in Rocket Pharma's pathway here and beginning to bring to clinic, or first to the FDA, our potential gene therapy for myosin binding protein C3 in hypertrophic cardiomyopathy. So as you all well know, hypertrophic cardiomyopathy is disease of the sarcomere characterized by thickened hypertrophied walls, fibrosis, often outflow tract obstruction, very high left ventricular mass, and a small LV cavity, which makes the heart a very inefficient pump, and also high risk and with higher fibrosis levels of having arrhythmogenic episodes. So when we're looking at myosin binding protein C3, there are sort of 3 sort of genetic forms, 3 major categories. The homozygous group, biallelic infants who have truncating mutations, produce little or no functional protein. At birth, they have a severe neonatal cardiomyopathy. It's dilated, hypertrophied, very poor function, and these infants will die in the first few months of life or go to transplant. There's sort of an intermediate group that are compound heterozygotes who have one abnormal or truncating mutation in myosin-binding protein C3, as well as another sarcomere mutation. This group of patients tends to present in early life, pediatric age group, and they have significant symptoms, usually of arrhythmic or heart failure nature early in life. And then the group that we are targeting initially for our clinical trials will be the heterozygotes who have one functional copy of the gene and one truncating mutation. We know from myectomy studies that people with one truncating mutation have decreased levels of myosin-binding protein C3 and only produce approximately 60% of normal level. So that decrement, only having 60%, is enough to create that severe phenotype of hypertrophic cardiomyopathy. So just briefly, in the cardiomyocytes, the sarcomere genes here are where our target lies. The myosin-binding protein C3, in addition to being the most common mutation for HCM, is also of a good size to fit inside that adenoviral vector. The myosin-binding protein C3 is part of the contractile apparatus in the sarcomere. It serves somewhat as a brake on the speed of contraction. It can slow down the speed of the actin-myosin interaction and contraction. So when you have a truncating mutation in this gene, then you have low levels of this myosin-binding protein, abnormal sarcomere function leading to kind of this LV hypertrophy and HCM. So this loss of function and ability to replace the gene to produce more protein is a good mechanism from which to develop a gene therapy to replace that missing gene and to restore the protein function. So our scientists have developed a knockout model of the myosin-binding protein C3. This is analogous to the homozygote infants where they have, unfortunately my echoes don't work here, but they have a kind of severe hypertrophy, dilated cardiomyopathy, much the way the infants do. The mice manifest this at 2 weeks of age and have significant heart failure. So this is a good animal model for the homozygote form of the MYBPC3 cardiomyopathy. So we have a mouse analog of the gene that was given intravenously to the mice at 2 weeks of age, at which point they have developed this severe cardiomyopathy. And we have seen over time, so here we have changes in the left ventricular shortening fraction. Again, this is more of a dilated, poorly functioning LV. So over time, those are treated. The blue and the red had an increase in their, I'm sorry, the blue are heterozygotes. They do not manifest as disease. The red are the treated knockout models. So they have improvement in their cardiac function over time and remodeling of the left ventricle to be more analogous to the wild type. And so if we look kind of over time, so this little complicated slide, we'll start on the left here. The gray bottom here are the wild type who were treated just with vehicle. They had normal MyBPC3 function and genes. The red group are the ones who were treated, and the knockout group, and black are the knockouts who did not receive treatment. So you can see over time, so the normal course for LV mass in the gray, then you had the knockout mice in black here who develop a dilation, increase in LV mass, and kind of heart failure over time, whereas those who are treated with the AAV therapy in the red have a decrease in that hypertrophy fairly rapidly after treatment that follows more the course of over the course of their lives. They maintain that lower LV mass, slightly more normal than the diseased counterpart. And this is a durable effect over time, so many weeks after the injection. Similarly, there's a change in the ejection fraction. Again, wild type in gray here at the top, the mouse ejection fraction is high, up in the 70s. In the black line here are the knockout mice producing no myosin-binding protein C3 who develop heart failure over time with a decreasing ejection fraction, whereas the treated mice on the red have an increase in ejection fraction more towards the normal range. Importantly, we also saw in the treated mice in red here versus the knockout mice who are not treated, that there was a distinct survival benefit among the treated mice. There were no deaths in that treated group, whereas in the untreated mice, the normal lifespan of a mouse is somewhere around 20 months. There was a distinct death rate within that untreated group here over time. When we look at how this has transpired in the mice on pathology specimens, where again, this is, we're looking at a single dose of the of the gene therapy. The wild type shows in red staining for the myosin-binding protein. So this is kind of your normal wild type in red, top left. The one next to it is the knockout mouse who are only treated with vehicle. They express no protein. Whereas at the two groups on the bottom here, were treated with two different doses of myosin-binding protein C3 in an AAV vector. Both of these treated groups showed expression of myosin-binding protein in the myocardium. This was 4 weeks after dosing. So as a proof of concept, this has been very encouraging. So we're looking forward now to presenting our data to the FDA and hopefully entering phase 1B clinical trials in patients next year. So quickly to summarize, that we've really made brilliant advances in genetic diagnostics that really enable drug developers and hopefully gene therapy developers to really address underlying causes of cardiomyopathies, arrhythmogenic cardiomyopathies, and eventually other forms of heart failure and genetic diseases. So I really think this is going to be kind of the next wave where the cardiologists can make some true differences for their patients. But we are early in that discovery process. So gene replacement therapy for this type of genetic defect where there's a loss of function, where you replace the gene and can replace production of protein, is a potential treatment for certain conditions as we come through. Our company, again, is sort of working on the myosin binding protein C3. We're also working on PKP2, arrhythmogenic RV dysplasia. There's another company coming through with a BAG3 mutation treatment for dilated cardiomyopathy. So there are a number of initiatives coming forward here in the next years. So we're hoping to follow Rocket Pharma and be in early human clinical trials with AAV9 gene therapy in the next year. We'll be hopefully developing treatments that are both safe and efficacious, initially in adults, and then as we gather safety data to move into children and infants. So we're looking forward to more directed preclinical and clinical research on the horizon. Thank you.
Well, oof, such a fantastic presentation, and the data is very, very encouraging. But I have a question.
Oh.
Actually, I have a bunch of questions. The first one is, how many years we should live to see this working in patients' lives worldwide?
Oh, it is very slow. It may be 5 to 7 years to get this through all the approval processes. Yeah. So all the way through phase 3.
So I will continue to eat well,
Yes.
to exercise, to try to lower my stress, because this is the future. And it reminds me another question. Once I went to, I think that Dr. Sanjay Sharma from St. George's in London, he made a lecture, and the title was The Good, the Bad, and the Ugly.
Yes.
I want to change the trinomium, and let's see, the fantastic, the known, and the risks.
Yes.
Can you talk about this?
The risks, yes. So gene therapy, because it is this form, or the adenovirus, comes with some immunogenic risks. The adenoviruses are prevalent in the community. They cause subclinical disease. So many of us here have been exposed to these AAV9s. So we will be doing screening for pre-existing neutralizing antibodies. This is standard for the AAV therapies, to find initial patients who do not have pre-existing antibodies that would attack the capsid and render the treatment kind of ineffective. Mm-hmm. Once one has selected that group of people with no pre-existing antibodies, when you give the AAV gene therapy, sort of depending on the program, people have given anything from just corticosteroids for temporary immunosuppression during the initial phases to prednisone and sirolimus, some of the anti-rejection drugs for use in heart transplant. Other groups are using rituximab and other immunosuppression to reduce that pre-existing antibody and kind of memory T cell response. So to give a gene therapy also means that we would be giving a sort of short-term number of weeks immunosuppression regimen as well. So that's a lot of what we're working out in the early clinical trials.
No cancer?
No cancer yet. There was a methylmalonic acidemia AAV9 trial in which 2 children developed hepatocellular carcinoma. That was subsequently found to be related to hepatobiliary disease associated with the methylmalonic acidemia, and not the AAV9 vector. However, we're early, and when we plan our trial, it will be treatment with at least 5 years of follow-up. So
Right.
we're all learning from one another.
So, questions from our lecturers?
Laura, I have one question. It's just to explain to the audience the concept of target of
Yes.
gene therapy and how to avoid with the measure on the development.
How to describe what? I'm sorry, which part?
No, it's just to explain the concept of target of the gene therapy, and really which after the development of the new protocols, just to avoid these adverse events that could be related with gene therapy.
Yes. So this particular one forms an episome, so it's separate from the rest of the patient's genome, and cannot be transmitted to subsequent generations. There are other forms of gene therapy with the editing that actually change the DNA. So I know less about those, but those may carry other risks. Again, all very early, so we're still learning. I know there's been a huge grant given through Cure Heart to Hugh Watkins and Cricket Seidman at Oxford and Harvard to start developing. I think they're more focused on the gene editing form of therapies for this. So there's a lot of interest and early research. So I think we'll be learning more shortly.
Thank you.
Luciana?
I also want to mention something. First of all, I was very happy with your presentation. It's fantastic. We stay all the time thinking about each patient.
Yes.
It's really amazing. It's a passion. And I would like to ask you if is there any allowed spoiler in PKP2?
Oh yeah. Yes. So we're filing an investigational new drug application for this program shortly, and then maybe in couple months we will have one very, very shortly for PKP2.
And
similar.
Okay, that's what.
Yes.
Yeah. Thank you, really. Thank you
AAV9 vector. Yes.
For this amazing presentation.
Yeah. No, and when you see patients and then families, and you see multiple generations having very bad disease, there's a lot of hope here.
Laura, Professor Laura, since Luciana, she's a electrophysiologist, let me ask you, is there any reason why any iron disease gene were not tested?
Oh, so yes, we've been looking at the long QT syndrome. We've been looking at potential targets. So depending on the target, a different, whatever the genetic mechanism, may have a different form of gene therapy to address it. For this, PKP2 and MyBCC3 fit inside the AAV9. I believe that we did look at the long QT genes, and unfortunately they didn't quite fit for this. But
so since this sarcomeric and the other one, this mosomic genes, they are being studied, can I say that the heavy chain MYH7 and other desmosomic genes can be studied as well?
Yes, unfortunately, myosin heavy chain, again, is too large a gene to fit into the AAV9 vector, but it may be one that benefits from a gene editing approach or something. So
I have another question. This is something that probably only a crazy guy can think about it. I remember a paper by Rollins, Mary Barron, and Barry Maron, Martin Maron and Barry Maron. 2 years ago, Jack, is a state-of-the-art paper. And they show an image that I present sometimes in my my lectures. a father and 4 kids, 30 years of age. And the father, he has basal cardiomyopathy. One kid, one son, he has asymmetric septal cardiomyopathy. The other one, a girl, she do not have the phenotype, and the other one was the only one who did not get the disease. So 3 different siblings, and they have the same mutation as the father, but the phenotype is completely different. Well, my question is, do you think it is possible to have a specific gene therapy for a specific phenotype?
No, that's an excellent question, and
it's not a crazy question.
No, so yes, we can busily, announce what the genetic mutation is, but then, what happens with the phenotype or who expresses it over time? How do you predict penetrance and expression are big questions. And so we're embarking on a program that Diego just alluded to with Health and Code to look at the genotype phenotype correlations over time. It's been hard to get sort of more population-based data or large family histories. Just in the literature, people often have their own little group. So I think now with the advent of better genetic testing and large databases like Health and Code has, that we can really start to unwind, what are these relationships between genotype, phenotype, and progression of disease. So still a lot to learn. But
and what about why do you Rocket company and your company they decided to study diseases that are deadly diseases? Is the fact that when you are very ill, everything you do is the best, can help?
I think so. Especially for something like Danon disease or the spinal muscular atrophy, these are lethal diseases. Our initial intent was to treat the homozygous infants who had no other option, but FDA would prefer that we get adult safety data before we embark on that. So our group of patients are adults with MYBPC3 hypertrophic cardiomyopathy. So they're not, they probably have a near normal lifespan expectancy, but the group that we plan to study have fairly severe disease. They almost have a defibrillator. They must have had disease developed before age 40. They have a number of sort of risk factors to make them kind of balance the risk benefit in a phase 1 study. I think given the newness and what we're learning about the immunogenicity of gene therapies, I think they've been targeted more toward the lethal diseases. And as we learn more, hopefully we will be able to, now we're talking at least 10 years out, perhaps when we have a safe version of this, be able to treat earlier in the course of the disease so you don't have to progress to having the really severe arrhythmias or significant hypertrophy. And as a pediatric cardiologist watching, these diseases present early in life in a more pronounced form than some of the adults, that ability to transform the course of the disease is very intriguing, but still in development.
Okay. There is a question from the audience.
Yes.
Gabriel Carvalho is asking, can gene therapy be used in patients with newly diagnosed type 1 diabetes mellitus? Is it possible to prevent or reverse this condition with any gene therapy?
I am not aware of anything being developed in that area, but that's partly because of where I've been focused. That would be an amazing target. That would be transformative.
Okay. Diego, Luciana, Jorge, any other question? No?
Okay.
Okay. So I have a last probably two questions. One is if you need, we have patients here in Porto Alegre and a very well organized center for investigation. And
Yes.
Luciana, for sure, in São Paulo, in COR, she has the same as well. So
Excellent.
we are doing this. We want to be centers in the future, and I discussed this with Natalia Patterson-Sonicheva before. So,
yes.
and the second question, I don't know if you will be able to ask me what I should do to work with you in San Francisco and live again in the Bay Area.
Come give a guest lecture.
Great. Okay. Thank you very, very, very much, Dr. Laura, to be with us. I think it was a top of knowledge lecture. We are in the future today. I remember that movie Back to the Future,
yes.
When we were, it was number 1, number 2, number 3. It was really, really, really fantastic. And I think you just finished with, I don't know how to say cereja do bolo. I don't know if there is a expression in English that there is in Portuguese, that it was the tip of the cake, the cherry of the cake. I don't know if there is this expression in English.
Yes,
Yes, so it was a very tasteful cherry of the cake, and everybody is writing over our chat. Congratulations, fantastic, very good. And Luciana and Diego and Jorge, who are with us during the whole morning, I think they shine as well with their questions and their knowledge. So thank you very, very much, everyone, to be with us this morning here in Porto Alegre, and afternoon and night and evening somewhere else. I think this kind of online virtual event, besides being very cheap, it's something of our time. It's something fantastic, and all of us, we learn a lot. Again, thanks, Natalia, for inviting Laura to do this brilliant presentation. Thanks, Luciana, Jorge, Dieguito. I'm very happy. I'm really, really very happy. Thanks for the audience as well, the questions, and the fact that you are with us today and in the last weekend was the reason for this symposium. Thank you very much. Have a great weekend.
Thank you.
Bye-bye.
Thank you.
Thank you. Thank you too.
Have a good weekend. Bye-bye.
Pleasure. Bye-bye.
Bye-bye.